Great.
Great, welcome back.
Thank you.
Continue.
Okay, so we already talked about everything on page 1.
Okay.
We talked about the first one on page 2. We talked about section 5 on page 2. And I believe we talked about section 6 on page 2.
I actually have a question on that one.
Did we?
We did, yes, about relaxing the credentialing.
Yep.
We talked about that, but I have a question. So and we'll all ask the same question of DFR, DEVA and the commercial payers, but have you talked to them about this? No, okay.
Oh, I've talked to DFR about some other programs. I don't think that one came up.
Okay, we'll make sure we reach out to them. Okay,
Lori?
yes.
Didn't we defer on section 5 and we're going to talk about it later?
What we said was that the hospital association wanted to propose some new language that would be consensus language. And so we're deferring to another day.
Okay, so we haven't looked at that.
Yeah, we're coming back to all of these
Right,
later.
right,
Yes.
okay.
So yes, we're waiting
I just
for
wanted to
Roz
keep
to come
track
back.
of it.
Yep.
I think our hope is that the next thing we look at is Jim's bill. And
Yes.
it'll have all of the language and we'll be doing it that way.
Right.
Okay, so then I think we talked about section 8. Is there anything to do on that?
We've not
No.
done section 8.
Okay.
So that is the one where I wanted to stop actually, because this is about the language in Vermont directs DFR to consider adopting and allows it to adopt emergency rules around cost sharing for COVID-19 diagnosis, treatment, and, one second. Yeah. Diagnosis, treatment, and prevention. So that includes things like COVID testing, antivirals, other treatments, and care if you do have COVID. It's a little confusing, and in fact, in our chart, and I won't pull up the other chart, but I linked to what I found to be a very helpful another chart by Kaiser Family Foundation going through, if you have this insurance, this is what's currently covered, this is what will happen when the federal public health emergency ends, because there are multiple layers here, which is the federal government has also put in place some coverage requirements. Those are going away. Now we have a firm date. We know those are going away in May. Vermont DFR also had requirements around covering antigen tests and other treatments. Those are also on, if we don't extend the deadline here, set to expire. So what that would mean is, for the most part, but again, I say it's confusing because there are also some permanent federal changes, but for the most part, requirements to either cover at all or waive cost sharing for some of these services would go away. It's confusing because it depends if you have Medicare, Medicaid, commercial insurance. I don't know that you want me to go into all those weeds right now, but the point is we are concerned that if both the federal public health emergency expires and DFR rules expire, there could be significant out-of-pocket costs for things like antigen tests, whether it's or a PCR test or Paxlovid. You've probably seen the coverage in the news about how much the vaccine manufacturers are proposing to raise their cost. Now, right together with the end of the requirements to waive cost sharing, people could have significant out-of-pocket costs. Again, Vermont can't touch Medicare and some of the other plans, but for the plans we can regulate in Vermont, we strongly urge continued coverage, especially for the vaccines and antiviral like Paxlovid, that those are really, and again, it depends on your plan. Some plans, if you have full vaccine coverage, maybe you wouldn't have out-of-pocket costs, others you would, but I would encourage you to hear, from DFR, from the payers, from the healthcare advocate, kind of what the impacts on patients could be. Obviously, COVID has not gone away. We want people to certainly be able to access rapid tests and Paxlovid if they test positive at a minimum. So I thank you for putting some attention into that piece of this puzzle.
So we will plan to hear from others. Okay. Art?
Is there a cost component to this?
Yes.
Yes, but it depends on the insurer, where that falls, right? So it would depend, I think that would look very different for Medicaid, which already does not have a lot of cost sharing. Probably, I don't want to speak for Medicaid, probably not a big cost impact on Medicaid. On the commercial side, it would not be a big cost. They've been covering this with no cost sharing.
Right.
But it would be, it would be a continued rolled into premiums, covering
And
those services.
we're helping with that. And this
You
is
have been helping with it.
cost.
This would be extending the help with it.
Okay, so, all right. Okay.
I mean, you have not been helping by covering the costs for people with
No,
private insurance, but
no,
requiring
no.
the insurers to pay for it or to
Okay.
cover it with no cost sharing.
Okay, so we are, all right.
Currently, if you have private insurance regulated by Vermont plans, or actually federally also under
Yeah.
federal waiver, there is not cost sharing for things like vaccines.
The state's picking up the tab.
No, your premium dollars
All right.
are paying for
Okay.
for
And
insurance.
I apologize.
No, no.
No, that's okay. It's confusing.
It is confusing because there also has, and I will add a layer of complication, which is the federal government also has been, so for say, let me just take the example of vaccines. There's the cost of the vaccine itself and then the cost of administering it.
Okay,
The federal government actually has been supplying the vaccines. That will also at some point be ending with the end of the federal health emergency. So that will also be a change. And then the question has been the administration fee, like who pays to actually put the shot in your arm?
yes.
That has been with no cost sharing, because if you have private insurance, the insurers, your premium dollars cover the insurer providing the full cost of that without a cost share.
Okay,
And the question before you with this bill is, do you extend that or do you let that sunset, in which case people will have co-payments for things like vaccines or Paxlovid or other?
okay. I guess what I'm getting at is if we allow this to expire, and I hate to put it this way, but would the state save money? The general fund?
The only area where the state could potentially save money is in the Medicaid program. And again, because you'd have to ask DEVA, but since there is already fairly limited cost sharing in DEVA,
So it's
I think it would be fairly minor, but that's obviously a question for DEVA.
And we'll make sure
It's
that.
more of an impact for commercial payers.
Yeah.
Okay,
That's who's, I think the most likely to have a concern about this would be a commercial payer, because they would be absorbing the cost of the cost share that we're not paying.
mean,
and are they spreading it out on to their,
I think you'd have to talk to them, but that's pretty much how it works, right? That's what a premium is. Yeah.
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 And I don't think, another question would be, this not only requires the no cost sharing, but it requires the coverage in general for these services. So I don't have any sense that they would or would not, but things like, now you can get if you have commercial insurance, you can get 8 tests at no cost share. So the question is, to the commercial payers, would you even cover 8 a month, or would you cover only 2 a month? And then what would the cost share be? So it would, again, not to presume they would do that, but at least there would be no requirement that they do that anymore.
Alyssa.
So I guess my question is, we extend this to March 31st of next year. All those same reasons are going to be present on March 31st of next year. And at what point do we just say, this is like anything else? Why are we singling this out? I mean, people die of the flu every year. Influenza is endemic. We don't mandate 100% coverage for influenza. And I guess the point is, it will never end. When do we start treating this like it's just maybe another part of our broken healthcare system?
All right.
If you don't mind,
No.
I'm not a witness, but I think we don't know enough about COVID and long COVID yet to compare it to the flu. They're both deadly, but I wouldn't be ready yet to let go of that.
I think it's certainly a policy discussion for the committee, and you'll see in our notes in our full chart, we actually ask whether the committee should consider making some of these permanent requirements. And it's a question, this is above my insurance understanding, and Jen or other witnesses may be able to answer more. Like many preventive vaccines are already required under the ACA to be covered at 100% as preventive services. I don't know whether this currently falls in that category or not, especially because it's under emergency use authorization rather than fully approved. So I don't know all of the various loopholes that may or may not apply in this situation, which is one of the reasons that at least a temporary extension may make sense. I will say, I think our organization feels most strongly about the testing and immediate antiviral treatments, then perhaps like if there was inpatient care required, for higher level care, I think it's a fair question at some point. Do we say that's treated like any other intensive inpatient encounter? I think the wanting to make sure that patients have no disincentive to do a quick rapid test, I would probably say if we had that for the flu, I'd say we should do the same for the flu, really. I mean, we should, if that's really is a preventive service. I don't know if under the ACA, those things are yet defined that way, that they would be covered as a preventive.
Devin, I saw you pop up. Did you want to add something and then we'll go to Brian?
Yeah, no, I was going to agree with Representative Cordes in terms of not knowing all of the effects of this, and anything we can do to encourage treatment sooner so that we're not having a lot of inpatient costs would be helpful. And then the other piece is in terms of inpatient costs that are not covered, those do go towards uncompensated care at hospitals, which hospitals then either absorb some of that or pass along as well.
Brian?
So, just two questions, like one, that currently, are all COVID-related services supposed to be covered fully without any copays or deductibles?
Those covered by the DFR order, so I think DFR should answer that question, or Legis Council. It is not, I don't know if it covers the entire world of everything. It lists specific codes and diagnoses.
Because the reason I ask is I actually have a bill for my COVID treatment. Like I was sent a bill and I refused to pay it because I said I thought this was covered, and it's still lingering over my head, this debt. And then the other thing is long COVID treatment supposed to be covered? Because we're talking about what we don't know. Like some people still have symptoms like a year after getting it, like myself. So is long COVID treatment covered?
I think we need to look at what DFR has said.
Okay.
Yeah, we just did not go into this level of depth in this
okay.
issue. Yeah, fair questions for sure.
So we will have them all come in. Leslie?
Oh, maybe I missed this. Did you comment on the second bullet? Modify or suspend health insurance?
Thank you for asking. I'm not sure we did, we should have said we are comfortable with that piece expiring.
So the modify or suspend health insurance plan deductible requirements for all prescription drugs.
And I think that DFR, I'm pretty sure, though again, DFR can clarify, this only gives them the authority to adopt these rules. It does not require it. And I don't believe they currently are requiring that second piece anyway, or whether they did, if they did, it was for a short amount of time. So I don't think that is currently in effect.
I'd be curious about that, but because that would be huge, right?
Yeah, I'm pretty sure that is at least not currently in effect if it ever was.
Right. So again, this is just what they could have done, not that they did do
So
it.
can I clarify? 'Cause
Yes,
I think
please.
I misunderstood. So the coalition is not recommending extending the DFR authority to modify or suspend deductible requirements for prescription drugs?
Correct.
Yeah, but I think we weren't clear, Jen, which is why you weren't clear.
We weren't clear in our comments, but no, we don't
Okay.
think that's
Thank you.
necessary at this point.
Not reflected accurately then in the draft.
Okay,
I can-
Alyssa.
Oh, yeah, also, I'm really curious as to why you're advocating to allow the telephone triage to expire.
That is another one that DFR has already allowed to expire, is my understanding.
So we will talk to them. I didn't know that. Okay. Are we good to go on? Okay.
Okay, let's see. I think, did we already talk about section 9?
So you're
That's-
allowing to expire.
Yeah, oh, right,
Yes.
we said allowed to expire, right, okay.
I will just say, we know buprenorphine's in the other committee. We would look forward to working with them
Okay.
on that.
Bed hold days. Allowed,
Right, so page 4,
yeah,
you're allowed, okay, so the last row you're allowing to expire, okay?
yeah.
I'm worried about, oh, sorry.
Sorry.
I know we have someone here that, I have a concern about long-term care facilities and the impact this would have on them if
If you're willing to.
Sure. Laura Pelosi, I represent the Vermont Healthcare Association, which is a trade group for our long-term care facilities. So, this was one of the things in the room in March of 2020 that I said we've got to put in there. To my knowledge, it's never been used. I had one facility that did attempt this last year, but it's just not something that AHS has used. And I think it's because they've been trying to provide financial support in other ways to facilities. So this just hasn't been a provision that they've tapped into. You have right to be greatly concerned about where we are with long-term care facilities, but I don't think this is necessarily the provision that's going to solve the problem.
Great, thank you.
I just want to make sure I understand. So if a person goes to the hospital because they have a stroke or whatever,
Right.
they lose their bed, well, what happens?
No, so for nursing home, so they're required to hold the bed. They have a 10-day bed hold requirement.
Okay.
There is some payment that goes to the nursing home, but what we were concerned about with COVID was that it could extend beyond a 10-day hospital admission. And then we were concerned about our residential care homes and assisted living residences also having that similar problem. So at the time we put this bill together, what we were looking for was how do we have quick infusions of cash into these facilities so that they're not left, trying to meet the needs of patients and be so cash constricted. But again, we've used a lot of other mechanisms over the last few years to at least try to support financially the needs that they have. And this just isn't one that the state has leveraged, even though they've had the ability to do that.
So in the current world, if patient leaves, they get to come back.
Yes.
That's all that's what I'm.
Yes,
The financial
so-
piece is
yeah,
one worry, and then the other worry is what
Yeah.
happens to the person.
Okay.
Let's see. 17 was we already talked about all of this. And we did have some, chatted with Jen a little bit about what this implies for the drafting. So I think that it sounded like the Board of Medical Practice, as David Hurley also started testifying, was focused on that telehealth piece that we all agreed could actually come out. So I actually think that's where they were too. And then what we suggested, you heard Lauren talk about wanting the flexibilities to apply only to professions if they haven't extended it. So we recommended that Jen draft it as Lauren is proposing, and then we may need to bring it back to our members, but that we sort of default to that as the next draft and consider it that way. But the Board of Medical Practice report that you don't see it here, but we suggested language that it sounded like David Hurley agreed to, we would want to see that.
Great.
That's different.
Okay.
They have not implemented any of those flexibilities.
And I have not looked at the draft. Do you have that language? Okay,
Yes,
great.
there is a section on Board of Medical Practice report based on their suggestions.
Okay.
I'll just add one other note that Lauren mentioned to us in her corner, is that, because I asked about the piece about requiring credentialing entities to accept a deemed license as licensure in Vermont. And she said, at least for OPR, they do indeed issue a Vermont license number, even if you're just deemed.
Okay.
So that at least logistically seems possible,
Okay. Great.
if that piece is.
And we'll still want to hear from the payers on this.
Yes.
Okay.
Yep.
Okay.
Okay. Let's see, 18, we said expires.
6, we're done.
7, we talked to them about 20 and 21.
We're gonna expire.
Yep, and then 22.
Oh, that's just
Yeah.
extended kind of already.
That's ended already?
Sorry, well, it's already, it's not time limited, though it's specific to COVID-19 exposure, so that's ongoing language, which is fine.
So page 8.
I'll just say another,
Top of page, we're on the top.
of page 8, section 26, this is the telehealth HIPAA flexibilities, and I just want to be clear, Jen probably already talked about this in the walkthrough, but that this is only to the extent permitted by federal law or guidance, and those flexibilities look to be going away with the end of the federal public health emergency anyway. So it's going to be time limited if allowing the language, allowing it to continue as long as it's allowed federally, at least just keeps it synced up.
Right, so we instead of having it end March 31st of this year, it'll probably end in May when the public health.
When the federal public health emergency ends.
Okay.
Right, but we
And
just want
that's-
to keep it all lined up.
And really, that, again, it's not about consent, it's about the technology you use being HIPAA compliant, and there's a little lack of clarity federally, and hopefully they will at least clarify this before the federal public health emergency ends around various phone technologies. So it's pretty clear, it's pretty easy to know, yeah, you're using a HIPAA compliant like Zoom function, like Zoom has Zoom for healthcare professionals, but it's less clear. Their guidance is like 3 pages long about using a phone, and is it a smartphone, and which app you're using, and is it or is it not HIPAA compliant. So that's actually the piece where it's a little fuzzy federally, and so it's helpful to have this flexibility.
Okay.
And just helpful for everything to line up, so we are just focused on one set of requirements and when they expire.
Okay. Section 15.
Let's see.
I apologize. This was a typo in our original materials we sent to Jen. This is asking for temporary licensure. It's actually not to remain consistent with federal flexibilities.
yeah.
It was to remain consistent with the piece about deeming.
Okay.
So that if we're saying above, you can continue to deem for that period of time. And while the Board of Medical Practice is doing a report about licensure streamlining, it seems to make sense to at least allow them to have the authority to issue temporary licenses for the same amount of time. I'm not sure they are actually using this flexibility. They are using the deeming. I'm not sure they're using temporary licensure, but at least keep it kind of synced up with the report coming back around how else can we permanently streamline licensure seem to make sense for us.
Yeah, I just made a cut and paste error when we put this table together. And then we're now doing file sharing. This is new for us. We're using SharePoint. And so then we sort of forget where we were when we sent something to someone, and then we keep making changes, and then we realize, oh, they're not caught up with us.
Right.
So
I just want to say one more second on the last row, section 12A on the pharmacist authority, because again, we had a little bit more of a chat with Lauren after during the break. And so this allows pharmacists to not only administer a COVID test, like literally do the swabbing, but also to order it. So to like put in the system that I am saying you need this COVID test. And that is being used often right now for the antigen tests. So you can walk into a pharmacy and say, I want 8 antigen tests. I want my insurance to pay for it. Well, if your primary care provider hasn't ordered it, the pharmacist is actually, they're using their authority to prescribe that. And then it can get entered under their prescription, and it gets covered by your insurance. So talking further, we actually are worried that could go away. So whether it is, and it sounds like, again, I would maybe, Lauren, you could follow up with Lauren, that it would be cleaner to keep it in here rather than put all of this in the other OPR bill they're talking about vaccinations, but that ordering the tests should probably just get rid of the sunset and continue permanently. Assuming there's
allowing pharmacists to order the test, which would be for the purposes of insurance coverage, of whatever your insurance coverage is.
So your
tests, which you could debate separately, but it would, right?
Right.
Yeah.
Okay, so we'll have to hear from BDH on that.
Might that probably other tests like flu or something? I mean,
I don't think there is such a thing, is there? One you can get from a pharmacy?
I don't know about the pharmacy.
I think like point of care, like at your
Pregnancy test.
That's over the counter. That's over the counter.
Also, it's a
No, not when you want your insurance to cover it. And so
That's what I'm saying, yeah.
Sometimes you still can with over the counter things. And there are some items actually in the OPR bill that Lauren referenced that passed a few years ago that has some pharmacy prescribing authority. They now can prescribe things like birth control.
Oh, okay.
So you can walk into a pharmacy, talk to the pharmacist, they can prescribe certain things. But it has gone through a protocol adoption process where the Department of Health and OPR have worked together and said, yes, you can do this if you've screened for these things, if you've done X, Y, and Z, then yes, you can actually be the prescriber and get something covered, even if it might be over the counter. For example, they're talking about emergency contraception in the bill downstairs for the same thing. Like, could a pharmacist prescribe that so that then it gets insurance, you can not only get it, but also your insurance can cover it.
So in addition to VDH, we should hear from pharmacy, Board of Pharmacy, and/or
And the payers.
And the payers.
Well, and I wonder, just as we think about this, just process wise, if it might make sense for you as a committee to consider on this one in particular, and I think also going back up to the other one on coverage, allowing it to continue, and then also maybe still pursuing what would it look like permanently, if anything, so that we don't run out of time on March 31st.
Yeah, exactly.
But instead of waiting till next year for us to come back and like put our heads back into this to tell you what we think we should do it now too, so that anything that you extend might not be necessary, say in July or August or whatever.
Good point, because just for the committee, we have to get this out of this body, through the other body, and to the governor for signature by March 31st.
Right, otherwise everything goes away. Right. There's a gap.
Right. Top.
I have a question about just walking into any pharmacy and having that pharmacist prescribe a method of birth control.
I think that's outside the scope of this bill. Can we talk about that offline?
Yeah, we can.
Okay. That's because it's way off topic of this.
You know,
It was an example.
It was an example, maybe
So I
not.
thought I'd let you know how I feel.
Let's talk to you at lunch.
Protocol around which methods and when and how, but. happy to
Okay.
talk to it.
Let's keep going.
Okay.
going,
I think we're on the
sorry.
last page.
Right?
Yeah, we,
Uh,
and, the only, just mentioning, I'm actually not, maybe the Board of Medical Practice
didn't weigh in on what they meant by concerned I'm not sure what that means.
I think they're still confused about the telehealth language that was repealed last in.
Oh, you think this was the confusing thing? Okay. Okay.
So that one's gonna expire and the next one goes to Human Services.
Yes, the next one goes to Human Services. We do support making this permanent, and then if possible to draft it, it sounds like it's not so easy, making e-signatures, adding e-signaturing into that, but that would be in the other room.
Okay. Thank you.
Thank you.
Thank you.
Let's hear from the healthcare advocate.
Stop my share from the.
I will say this morning when I looked at our agenda, I thought, oh, this isn't gonna take us 3 hours. I know.
Complicated.
Or would have tears,
Or what?
or would have tears along.
Exactly.
Yeah. Good morning.
My name.
Mike Fisher, healthcare advocate. So I think I can be rather brief. I think I have only 3 sections of this bill to make any comment on. But also just the high level appreciation for the work. So section 5.
Wait,
So are you using the same,
that is on page 2.
that's the bottom section, right? When you say section 5, you're,
Yeah, so hold on, Leslie, I'm directing it from there. I want to confirm it's page 2 with the Green Mountain Care Board language?
Yes.
So page 2, section 5 of Act 91, the second row.
So I heard the discussion earlier from Vaz about wanting to work with the Green Mountain Care Board to find consensus language. Before hearing that, I was on my way to say, just FYI for the parties listening, we're not sure this is needed. However, we don't have a concern about giving the board the authority to waive some of its processes for, its regulated process, because we feel like the board has done a good job of using that power appropriately.
Okay.
Though I will also say again, I'm not sure it's needed because I don't think that's being done today. So when I hear, so if there is new language coming that focuses instead on CONs, I would be happy to work with the parties that are working on that language or come back.
Great, and Devin just popped up and with a thumbs up. Wonderful.
I was gonna text Devin, but I didn't manage to. So section 8.
Okay, hold on. This is the top of page 3, directing DFR to consider adopting and allows it to adopt emergency rules. That one?
Yes, DFR emergency rules.
Yes.
So I wanted to focus on that for a second, is DFR emergency rules that, we are talking here about, commercial insurance, not Medicaid or Medicare. This is commercial insurance, first dollar coverage for diagnosis, treatment.
Can you explain what first dollar coverage?
And so let me do that for a second. So let's say that you have commercial coverage and you need some care, you need a procedure done and it costs $100. The overall bill from the provider is $100. Depending on what plan you have, your premiums, the money that you pay every month, whether or not you get sick, your premiums maybe covers 80 of those dollars, and 20 of them come in some form of an out-of-pocket, your deductible or your, a copay. So I'm flying on a very high level. So the overall cost is still $100. Does it come out of your right pocket when you pay your premium every month, or does it come out of your left pocket when you go to the doc? That's what we're talking about here.
When you say first dollar coverage.
When I say first dollar coverage, I'm saying all of it is covered through your premium dollars. So to the extent that you're shifting any money around, it's really just saying, hey, insurance company, you need to fix the rates, recognizing that the full cost of this care is going to happen through premium dollars. Is that clearer or more confusing?
I think it's clear, Mike. You're looking to be specific.
That was helpful for all of us.
There's no impact on the state, on revenue fund here. This is wholly about, this all comes out of the consumer's pocket. It's just about when it comes out of their pocket.
Okay.
And I support the proposal because we don't want any financial barriers to people getting care, this kind of care, when they need it. And we do know that deductibles, hey, people are walking around with $15,000 deductibles. And that interferes with them getting the care that they need when they need it. So when there's a public health-like concern and we want people to get vaccinated or tested or an antiviral in particular, we would weigh in saying, should be no barriers. We want people to get this care as quickly as possible. It protects all of us. So.
Okay.
If that's the case, why don't we make it permanent? If there's no disincentive, I don't know.
Yeah, I think the discussion between other members about why COVID and why not other things and when does COVID just become a regular, I think is probably the right answer. That discussion leads to the right answer here. We're still figuring this thing out.
Yeah.
I would also add, we do have the, what's it called? The vaccine purchasing program. So for pretty much all vaccines, the state has a purchasing pool that buys vaccines, for the whole population, and at a lower, we save money by doing it this way. And I just don't know the answer to the question is whether there's been consideration about adding COVID vaccines to that. That would be my question in follow-up to that discussion.
Okay.
Just a general observation, I guess. Mm-hmm. If the Federal Emergency Act is going away in May, why would we consider extending something like this? I don't get doing it, but that's just my 2 cents.
Yeah. I think
I don't know that enough people are affected by this COVID-wise to warrant it, but I don't know. I'm not.
Do you want a comment, or I'm gonna see if Jill wants to comment?
So I think the question was what, you're still on the co-payment, that section?
Yes.
So if the public health emergency is going away, why would we want to continue it? Well, I think the idea would be then any federal protection to allow for this kind of coverage would also go away. So if we wanted to continue to have the lack of cost sharing so that consumers aren't paying, we would need state protection to the extent that there's no if it's the federal. I think the projections all come from the state on this. I think it's all been state policy anyway. So, but I do think that is the policy question on the table is it time to say this is like everything else or is it not?
Yep.
Yeah.
And I also want to add, this is permissive. This is asking DFR to consider. And I would add, similar to what I said about the Green Mountain Care Board, I sit on the committees that discuss that consideration and feel like the board I feel like DFR and parties do a good job of reasonably making those decisions. And then the last one is a high-level comment about the discussion about section 12A at the bottom of page 8. And this is about pharmacists' ability to, just on a high level, I just want to say pharmacists are a key healthcare provider in every one of our communities, and we need to continue to appropriately use them. They are where a lot of people get care and get advice about care. And so I support that conversation about making sure that we continue to use them for access to, if it's just tests, and tests and other COVID-related care. And recognize, hey, we've already, we're losing ground on these things. I mean, we no longer have support for uninsured people to get a lot of this care at the pharmacy counter. The federal money has dried up. And we certainly hear stories from people who are trying to get care and for whom the financial barriers prevent them from getting it. So.
Any questions for Mike? All right, thank you, Mike. All right, so I think what we're gonna do, walking through this, Jen had drafted language for us, but walking through it, there are some changes that she'll need to make. So rather than bring something to the table that needs to be changed, we're gonna let Jen take her time in changing it, and we'll reschedule time for her to come back and walk us through the language. Once we have a bill and language that we've walked through, I will send that to all of the parties that we've talked about that we still need to hear from and schedule testimony with each of them so they can provide their feedback on what the coalition is recommending. And then obviously we'll have a committee discussion and, Art asked a good question. What's the policy around us continuing some of these with the federal emergency ending? And we'll just walk through each one and have a discussion about it. So that's the process plan. Any questions? Great. So we are back here at 1:00 for a security briefing with the chief. Here in this room. It's just, he's visiting all the committees.
Oh, that's what this is, the traditional.
Yes, traditional. Okay. And then we'll do a committee discussion and hopefully finalize the guiding principles this afternoon, which we have copies of. So it would be great if everyone could read them before we come to this table.
During lunch?
Whenever you have.
Before 2:00.
Mike?
I'm sure I forgot to say when I was in the seat, but while I was still on the record, I would say if any member of the committee or anybody has concerns about a bill that they have from a provider that they think that they're struggling with, I'm looking at Gina.
Thank you.
Feel free to reach out to our office.